Good afternoon, good evening, everyone. Welcome to Perspectives in Focus. This is James Hicks, and I thank you for your time. I thank you for joining us. Tonight is part two of a discussion that we had, I believe it was last month, with the Vascular Institute, right? We had Jennifer Valcazar online, and we talked in depth about your health. We talked in depth about peripheral artery disease. We answered your questions, which is fantastic and a great experience. But tonight we are blessed and we are fortunate to have, with myself and with Jennifer, we are blessed to have Dr. Adel Aitali with us. Dr. Aitali is a doctor of podiatric medicine, specializing in foot, ankle, and leg conditions, as well as reconstructive surgery, limb salvage, and wound care. He is definitely the subject matter expert on this topic, folks. So his doctoral degree from Western University and exercise science degree from UC Davis has earned him high honors. The fact that he went to UC Davis, we were already talking behind the scenes. I like the guy already. So if you got to see him, he's a good dude. Dr. Aitali's level of expertise, along with his genuine and compassionate bedside manner, is with us this evening and is going to be able to share a lot of information about peripheral artery disease, as we talked about before, and then some other topics as well. So please have your questions ready. Feel free to ask them. Don't be shy, because here is the man of the hour right now. Dr. Aitali, how are you, sir?
Very well. Good evening. It's good to be with you, James.
Thank you, sir. Thank you, sir. And Jennifer, how are you? Let me get you framed right. Oh my goodness, you moved from earlier on, and I got to get you back in business here. How are you, Jen?
Thank you. I am fantastic.
Good.
I am fantastic.
So let's go ahead and get started. Get into it, because we got. Hold on, you keep moving, young lady. There we go.
I'm right here.
There we go. Doctor, give us, so I talked a little bit, right, and gave you the high level there, but I would love to hear directly from your perspective, your elevator pitch, as I call it in my industry, right, in the technology industry. But how are folks to recognize you and talk to us about your field, your study, how long you've been studying, and the types of things that you focus on as well? It's going to be best to hear it directly from you as opposed to from me.
Certainly. As you mentioned, my degree is in podiatric medicine. I have a doctoral in podiatric medicine. I have focused study in the foot and ankle. I spent 4 years in undergrad, 3 years in grad school, 4 years in medical school, and then 3 years in residency. Gives you an idea of the amount of time, it requires to be in this field. I specialize in all sorts of foot and ankle conditions, as you alluded to earlier, from trauma to reconstruction to wound care to vascular issues. I was lucky enough to get added vascular experience as part of the Vascular Institute, where, working hand in hand with IR, interventional radiology physicians in treatment of peripheral arterial disease and peripheral venous disease as well.
So what does that mean, right? I mean, again, I guess for everyone who's listening, when they have an ailment, specifically, again, from a limbs perspective, and again, we had the conversation about PAD, peripheral artery disease, before. How does someone go about? Are you more from a specialist perspective, or are you someone that works at UC Davis, someone that works at Kaiser? How does, again, someone come and engage and interact with you? What does it take for someone to have to be in your office? I guess let me go to that.
Excellent question. So I am what you would consider a specialist. So usually the algorithm of getting to see me would be, generally speaking, you'd see if someone has an issue, they'll go to their primary care physician and present with a certain ailment. The primary care physician will usually refer them to somebody like me if they've got a specialized issue with a lower extremity that requires more expertise than the primary care physician can provide.
Okay. Jennifer, definitely feel free to chime in, because look, he may be the expert. I got him in the middle, but you are definitely, quite frankly, the right hand person right here, and I'm just here to instigate and funnel through the comments and things of that nature. But I do have a question about you, and we were talking about this before we went live, and you're not going to make me say the word, so I won't embarrass myself like I did last time, because it was way too many syllables. But let's address this. I'm going to try it. Hypercholesterolemia. Close?
Very well done. Excellent.
What is it, and how does it relate to PAD, peripheral arterial disease?
Okay. So hypercholesterolemia is essentially just a higher level of cholesterol within your bloodstream. Now, cholesterol is not necessarily a bad thing. Cholesterol is naturally made in the liver, and it courses through your bloodstream. We get in trouble when we consume too many foods that have high level cholesterol in them, because then that increases the amount of cholesterol within your bloodstream a significant amount. And the problem with that, as it relates to peripheral arterial disease, is the cholesterol aggregates, or it collects in the inner lining of the arteries. That's a problem because it can get to a point where it occludes blood flow, or it limits blood flow, as that cholesterol hardens, and it starts to create a larger and larger blockage, to the point where your arteries can be 50% blocked, 75% blocked, 90% blocked. And of course, as you decrease the amount of blood flow to your lower extremities, you are going to have some significant repercussions, ranging from as mild as something that we call claudication, which is pain in the muscular portions of the leg, to the more severe cases where you end up with gangrene, and you end up having to undergo amputations to remove the gangrenous or dead tissue in your feet/toes.
And obviously that's worst case scenario, right? So
of course,
before getting to that stage, obviously, folks, you all know if something's wrong, something doesn't feel right, you know it, right? We all know our bodies, so pay attention to that. But I guess best practices or recommendations for making sure that we don't get to that, and almost kind of leading the question, because I kind of know an answer that I want to hear, right? It's movement, exercise, those kind of things, proper nutrition and things like that. But I would much rather hear it from the guy in the middle, kind of thing. And again, just making sure that we don't get to those points to where we have those types of those issues. Because from a cholesterol perspective, I know high cholesterol runs deep in my family, so it's genetic. My number is, if I told you my number, you'd fall out your chair. But I am on a statin, and I eat pretty clean. But it is one of those things. But again, preventative measures. What do you have in terms of recommendations for that?
Sure. So let's talk about the risk factors for peripheral arterial disease before we begin talking about preventative measures. So age. Age 50 or higher, your risk automatically increases for peripheral arterial disease. Smoking increases your risk significantly of peripheral arterial disease. Diabetes, high blood pressure, high cholesterol, all those increase your risk factor, your cardiac risk factors, or your risk for getting peripheral arterial disease. So having those under control all goes a long way to reducing your risk of peripheral arterial disease. As far as things we can prevent, as you mentioned too, exercise is an excellent way to minimize not only the risk of peripheral arterial disease, but a whole a bunch of medical conditions that could be problematic in the long run. So exercise, if you smoke, you definitely have to quit smoking, because that is the number one variable that affects peripheral arterial disease. And then, of course, good diet, maintaining good blood sugar levels, and preventative measures such as seeing your health professional as soon as possible, because these issues of arterial disease can be managed with less drastic measures if they're caught early on versus when the artery has completely occluded and now a more significant surgical intervention is required.
Interesting.
So James,
Yeah.
in part one, we did discuss, the importance of preventative measures of getting a screening. And so the first portion was actually huge about that in discussing how each measure was performed. We talked about the ankle brachial testing, and then of course going to the Doppler, and then the ultrasound imaging. So those three components, actually help to dissolve any issues. And if there are, then that's when Vascular Institute's doctors step in and advise what type of procedures can be conducted.
Excellent. Appreciate that insight as well. I guess let me ask you as well, Jennifer, because that just begs a question that I have as well. The network of doctors that you have, in my research and just preparing for this session and our previous session, I noticed Vascular Institute is nationwide, right?
Yes. Actually, we're planning to go nationwide. We actually have a couple of clinics in Texas.
Okay.
We have some in Arizona, and then of course Sacramento. But the goal is to definitely be nationwide.
Okay.
And yeah.
Well, I say that for folks. There's no excuse. Folks listening and watching, right? It doesn't matter if you're living in Dallas right now or if you're in Richmond, Virginia, or Sacramento. There's no excuse for finding this type of care and things of that nature. Let me ask another question. So, diabetes, right, and kind of a connection with diabetes, and you gave me another long word here, Jennifer. Diabetic neuropathy. And peripheral artery. I am just expanding my vocabulary right now. I'm being selfish. This is all about me right now. I am dramatically expanding my vocabulary. Explain the connection, I guess, like I say, of diabetes, diabetic neuropathy, and peripheral artery disease, please, sir. All
right. So diabetes is referred to as the silent killer for many unfortunate reasons. So at its most simplistic terms, diabetes is basically the increase of concentration of sugar in your bloodstream. That can lead to a significant amount of ailments. It could be because of lack of function of your cells within the pancreas, the cells that regulate insulin formation. So bottom line is there's an excess amount of sugar in your bloodstream that isn't well controlled. So diabetes essentially causes inflammation of endothelial and smooth muscle cells. And basically, those are the cells that make up arteries and other connective tissue within your body. So when there's an inflammatory process, the homeostasis or regulation within your body is thrown haywire. How does this affect, what we're talking about? Well, one, it leads to something called diabetic angiopathy, which is the actual disease, the inflammation of the blood vessels that have your circulation go through. Those are the arteries. A little aside, diabetic neuropathy is the effect of increased blood sugar on the nerves. So the way in which neuropathy and angiopathy tie in for our patient population is you'll have these individuals with neuropathy. They can't feel anything wrong with their lower extremities. They may have clogged arteries and poor blood flow, but because their sensation is so off, they're unable to fully appreciate the pain and discomfort that they're in due to lack of sensation.
Say that again. That's profound right there. Say that for me again. I need to digest that.
Okay. So diabetes causes diabetic neuropathy, which is lack of sensation because of affected nerves.
Right.
Diabetic angiopathy is blood vessel disease. Okay. So the way in which neuropathy and angiopathy are related is, as far as peripheral arterial disease, is folks aren't able to fully feel their lower extremities, and they can't tell pain, because with neuropathy you lose the gift of pain. So you
Okay.
can't appreciate certain things. And one of the hallmark signs of angiopathy or peripheral arterial disease is certainly pain from lack of blood flow. We call that ischemic pain.
And through diabetes, you don't have that feeling. So progressive, and so layman talking here, right? It just progressively gets worse. You don't know it, and then you get to some of these
Exactly.
other stages that you were talking about, the gangrene and maybe the need for unfortunate
You
amputation.
got it.
Interesting. Okay, so folks, definitely watching and listening, and after we're live, Doc, this session will also, I'll pull the audio down and turn it into a podcast. There'll be another handful, another segment of folks that'll catch this content. So hopefully they heard it the second time, because I really wanted to hear that myself, and also for the listeners and the viewers. Jen, what do you got? Yeah, I got a couple of questions that you sent me, but I don't want to be. I want to be cognizant of you as well, because you are definitely the physician liaison that came in and set all this up. So I'm humbled and thankful for that.
You're a pro, James.
Well,
I have complete confidence in you.
You might want to Google me. I do this. I do this once in a while.
Hey, I actually Googled you today. One of my friends was like wanting to hear all about your podcast, and I actually got her to subscribe. So she's really excited because she is learned about your In the News podcast.
Okay.
And I think that's really fantastic. And so, so how about we pull up that picture, the one that has the before and after.
The one that is,
yeah, so it has like the look, shows the arteries, and then you can ask that question.
Is that this one?
Yes, sir.
Make sure I got it lined up there, right? Oh my goodness, that's when I saw that, I was like, man, see, folks, you don't want to get to this point here. So, okay, talk to us a little bit.
So, in conjunction to what Dr. Aitali was saying about neuropathy in connection with peripheral artery disease, is that this photo here definitely shows, a foot that has, some tremendous issues. Maybe it was because of neuropathy; they couldn't feel that pain that Dr. Aitali has indicated. But for example, when someone does have a foot wound and that it hasn't healed, how can Vascular Institute help? So Dr. Aitali, talk to them about that.
Okay. So the unique thing about our centers is the interdisciplinary approach to managing these vascular issues. And what you see there, that's a vascular wound. That's what we call an ischemic wound. So from peripheral arterial disease, from poor blood flow. Okay. So the nice thing about having an interdisciplinary approach to this is, one, you come in to see somebody, they need to determine what is going on. Why is this wound here? So there are three reasons mainly why a wound doesn't heal. One, infection. Two, pressure. Or three, poor blood flow. So our job is to determine what is the cause of the chronicity, or the reason why this wound has been there, has not healed. Any wound should be well into healing after a few weeks, usually within a month. A wound, there's no reason a wound shouldn't be healed if all things are being taken care of. Right. So what's most important is getting an appropriate history from the patient, determining what factors may be contributing to the lack of healing of a wound. Two, determining for ourselves why it is not healing. Three, being able to have diagnostic tests and screenings to determine what the blood flow is to this lower extremity. And then four, being able to manage this if this is indeed an arterial wound, treating it with an angioplasty, angiogram, however it is that we do manage these wounds, these issues of poor blood flow.
And that's what the X-rays are showing there in terms of the blood flow, because obviously I can see the one here at the bottom that I'm hovering over right now.
The bottom four pictures are that's essentially a picture of an angiogram. What an angiogram is a picture of an artery. Now, arteries do not show up on X-rays; they're not easy to show on imaging. So what you see there is contrast dye moving through the arteries.
Okay.
And it shows you when you see dark color, that means there's blood flow. When it's light, that means that there's no blood flow. So this arterial tree think of it like an upside down tree with branches going down. So flow should be consistent regardless of how small the arteries get. The lower you get into the leg, the smaller caliber arteries there are. So what you'll notice is there are areas where it's dark and then it goes completely clear and you can't see any more blood flow. That's an area of what we call occlusion or blockage. Now, our colleagues are able to get in through the groin with their tiny instrumentation, image this right here, and they're able to go after the blockage and puncture through it and remove it. Once that's removed, another angiogram is done immediately to look and see if blood is flowing consistently through that previously blocked set. If it is so, then perfect. Job is done. If not, then that's where a stent comes in. Stent is put in a place where that blockage persists, and that allows for more blood flow to consistently flow through that previously occluded portion.
Okay. Now let me ask this again, and I'm specifically asking in third person layman, because again, I really am, and I have a feeling that folks that are watching and listening have these questions, but again are either hesitant to ask or whatever the case may be. Now, Jennifer, we were talking last session about the procedure and it being essentially a one day. You're in for a couple of hours. You're evaluated afterwards, and then you're done. Is this the same procedure that you were just referring to, doctor, in terms of, again, you come in, you're on the table for 2-3 hours, whatever the case may be, you're evaluated again, and then at the end of the day, you can still go home, or is there a longer stint?
No, then you're absolutely right. So I always ask patients to donate 4 hours to the cause, 4 hours of their day. I have them. So I tell them the procedure will take anywhere between 45 minutes to 2 hours. And that depends solely on the complexity of the disease that we encounter while we're in there.
Okay.
So we want them there usually about an hour before the procedure, and we want them to stay with us for about an hour after the procedure, just to make sure things are going well. So 4 hours, and they're able to go home that same day. Patients ask me frequently, hey, what's the downtime for something like this? I say, there really is no downtime. I tell them, as long as you're not out running a marathon, doing jumping jacks immediately after the procedure, you should be okay. They tell me, well, I wasn't able to do these before anyways. So then there's no issues.
You're not the bionic man, and we're making you that many times better, but we're right. Correcting some issues. So that's a good point. Right. Again, I don't like to assume, so I wanted to actually have that conversation as well. So good stuff. Jennifer, let me throw it over to you again. I've got a question I do want to ask the doctor, but I wanted to maintain the flow and make sure that we're staying on point with the topics that you wanted to cover as well. So,
yeah. So when in the first session, what you just said, James, really holds true about surgery versus outpatient clinic, and that's the amazing thing about Vascular Institute is we are outpatient, and it's such a tremendous value, not only for the patient, but for their primary doctor, for their family, even for us, because there's satisfaction in knowing that this patient is going to walk out and feel a huge relief upon discharge. And we talked about in the first segment that surgery is it's really sad and horrible because of the fact of the cost that goes into it, and also the recovery time, rehabilitation, and the fact that there's actually a scar. So, I can't emphasize enough about Vascular Institute and just the way that the interventional radiologists are specializing in this type of advanced technology. And Dr. Aitali will, definitely, his expertise is so wonderful, and the patients truly adore like I said, truly adore his bedside manner, because there are doctors, and I'm going to be, me, James.
She's going to
me,
say it. She's going to say it. She's going to be honest. I think we're safe.
I'm going to say it. There are doctors that are just really kind of tough, and maybe it comes with years of having, seeing so many things. But I'll tell you, Dr. Aitali is natural, and in his philosophy and also in his demeanor, and patients love that about him. And I that's also with our other doctors, and so the kind of the team that we have created at Vascular Institute is probably one that I'm very proud to say that I'm part of, because I know what lies behind the doors, what actually is taking place. And I just wanted to say that. That's all.
There we go. That was actually a softball. I threw it. I knew you were going to go that way, so I kind of threw that in your direction. But
thank you,
Doctor. Let me ask you a question about, I guess, demographic, right? Of the types of folks that you see that need your specialty. I mean, is it more younger folks? Is it older folks who have just gone many years, that have gone through periods of time not addressing something, or and you see a specific segment of society, right? Latino, Black, what are the, I guess, again, like I said, the demographics of the folks that come in that need your assistance on a regular basis?
Sure. So I tell most patients that peripheral arterial disease is not usually a young person's disease.
Okay.
Across the board, we see it with usually the slightly older population. And as far as demographics and racial groups, that portion depends on diet. So the individuals that have usually a diet that's consisting of more, as we were talking about earlier, more fatty foods, more cholesterol, certainly that's going to be reflected upon their peripheral arterial disease and those specific subgroups. But for the most part, it's across the boards for the not so young, so to speak.
Gotcha.
However, that's not to say that it doesn't happen in younger individuals, because we have had some younger individuals with some genetic mutations that have led to what we call coagulopathy, or issues with clotting within their arteries due to their genetic mutations, and that's a real risk for those patients with those genetic mutations. So it is not a young person's disease usually, but of course, you never say never.
Gotcha. In terms of what you're looking for, right? When someone comes into your office, or maybe referred or sent in your direction, visual signs, right? That maybe, again, someone like me, again, layman, third person looking. What are kind of some of the visual signs that a podiatrist would notice, kind of that would be an alert to PAD?
Okay, great question. So from a physical examination, we look at the pulses. Can we feel the pedal pulses of these patients? If there are no pedal pulses, that there's no such thing as a normal foot that doesn't have pedal pulses. So there's got to be blood flow that is tactile, that's felt. Okay. Next, we look at the overall appearance of the foot and leg. Is there discoloration? Is there any presence of hair? Because usually if there's no hair on the foot or leg, that means there's not enough blood flow. We check the temperature of the foot itself. Is the foot cold? Is it warm? Of course, someone that has arterial disease, their foot is more likely going to be cold. That's not to say every cold foot has arterial disease. I want to make that distinction. But people with arterial disease can have cold feet. Next thing we check is something called the capillary refill test. We press on the toes, push the blood out of the toe essentially, and then remove our finger and see how quickly that toe fills with blood again. Now, a normal toe, a normal capillary refill is about 3 to 4 seconds. Anything beyond 5 seconds, leads you to thinking there is a problem with the blood flow. But more so than just the physical exam, the history gathering from the patient is very important, James, because there are things with arterial disease that are not present on physical exam. For example, I always ask patients, do you have pain in the legs? I don't mean the knee, I don't mean the ankle. I mean specifically in your calf. When you lay down at night and raise your legs, do your legs wake you up at night because of pain? When you walk during the day, can you walk 4, 5, 6 blocks without any pain in your legs? If there is pain in your legs, does the pain go away once you stop and rest? So gathering information from the patient is extremely important because it does help guide us toward a diagnosis of peripheral arterial disease. You take the history gathering with the physical exam, you marry that with the diagnostic studies, and then we've got a solid diagnosis.
Makes sense. Question here coming in, sir, is the blockage removal instrument a laser?
So we do use a laser to help in something called atherectomy, which is the actual removal of the plaque that's built in the wall. It is completely up to the surgeon's preference and whether they prefer to do it with sharp instrumentation versus a laser. It's all available. It can be done.
Okay. Thank you for the question. Thank you for the answer. Let me. I wouldn't save this question for last, and it's probably not going to be the last. But it was just a good summary, and I think of the dialogue that we've had here, I think it's just a good one to ask. The importance of having a podiatrist in your life, right? I mean, you're dropping gems here, and you're telling folks really simple things to do to make sure that they maintain their health. All right, we've talked about nutrition, we've talked about movement, we've talked about noticing symptoms and addressing them. I may have answered the question myself, but I guess the importance of that medical team that everyone has, right? Everyone's got Medicare, Medi-Cal, Kaiser, whomever, right? They've got the health insurance, and we know who our primary care physician is. But I wonder if a podiatrist is someone who we need to make sure is part of that core team as well. Not just someone that we go to when it's all bad, right? Is someone with, I know you're more of a specialty, but again, I guess let me ask that question. Is a podiatrist someone that we should have, again, as part of that core team that we have, and that core tool that we have in our toolbox for our health and wellness and things of that nature?
Short answer is absolutely. And the long answer is here's why. By the time you have complications and pain and discomfort, it may be a little late to be referred. So having this day and age, we focus a lot on preventative medicine, both for better outcomes for patients as well as doctors. Mm-hmm. So having a podiatrist as part of your team, you've got a specialist that takes care of your feet and legs and only your feet and legs. You reserve your migraine issues, your low back issues, everything else goes to your primary and other specialists. But you have someone that is dedicated to just your lower extremities. Everybody that comes in through the door should, I say this because I'm a specialist, but everyone that sees their primary care physician should be screened for any issues with lower extremities, whether it be arterial disease, neuropathy, wounds, what have you. Your primary care physicians are tasked with such an incredible role of managing all of your issues that sometimes the smaller things may not always get addressed as quickly as they should, simply because of the mountain of symptoms that they're having to work through. So having a podiatrist, someone dedicated to your lower extremities, I feel is extremely important. Now, of course, that is my bias because I'm one of those people, but
it's okay.
Absolutely important. Yes.
Awesome. Now, let me ask you again about that and the relationship that you and your practice has. Are you exclusive to the Vascular Institute, or are you're also working with other institutions and organizations as well? How is that working? I'm just kind of curious from the folks on the screen here, right?
So our corporation has the Vascular Institute. We have a podiatry clinic, and then we work in the local major hospitals. We cover the hospitals for foot and ankle issues. So that's how it works with our team here.
Okay. So you branch out, which is good. And again, that was somewhat of a lob, because I wanted folks to make sure that if they weren't, sorry, Jennifer, if they weren't in those 3 locations that you already are, and they're closer to you, Dr. Aitali, right? They could still work with maybe your team, right? If you were closer, things of that nature. But again, I guess the core of that whole roundabout thing was that don't overlook if you've got some issues. If you're feeling something, it might be time to go ahead and call and get that telehealth conversation going, because you can't really go anywhere right now. But definitely don't overlook any of these types of symptoms that you may have. Doctor, did I leave anything out that you wanted to talk specifically about? I want to continue the conversation, but I want to make sure I'm not overlooking anything that you wanted to share with the audience. I know we're getting a couple of questions in, but again, folks may be hesitant to ask or just don't know what to ask. Let me put it that way, right?
One thing I wanted to mention, going back to talk about diabetes and loss of sensation, neuropathy from it. If I would love your listeners to walk away from this with this bit of knowledge. Always check your feet if you're diabetic and you've got neuropathy, because most patients, again, with neuropathy don't feel pain. So if you cut yourself, if you experience a cut or an ulcer on the bottom of your foot and you're not checking your feet, you're not going to be able to tell that you've got something going on. Now, and if you got arterial disease on top of that, that is a recipe for disaster. So please monitor your feet on a regular basis.
I don't, it doesn't get much clearer than that for me. Right. Thank you for that, sir. Jennifer, in terms of your side of the conversation, do you have anything that you'd like to add? Again, maybe specifically any more screening events that the Vascular Institute is providing, or?
Yeah. So right now we actually have some partnership news.
Fantastic. Look, we're breaking news right here on Perspectives in Focus, ladies and gentlemen.
Yes.
I love it.
Yes, we actually are. So what's really amazing is our team, consists of, a team of ultrasound techs, our doctors, Dr. Aitali, our office staff. And, they get very busy. And yet we still want to support our community. So what we've done is we have aligned ourselves with a company called Lifeline Screening. And it is a company that does the ABI, the ankle brachial index testing that we had talked about in segment 1. But I'll go over that again for a quick minute. That's the initial test that our ultrasound techs or our techs will perform. And basically it is where they'll put the what's like a blood pressure cuff on the arm, and then also wrapped around the ankle to test for blood pressure. And based on the criteria If it's high or if it's low, the blood pressure, then they determine the next factor if they're going to go ahead and use a Doppler, which Dr. Aitali, he conducts that part with using the Doppler. So going back to this lifeline screening, what's really interesting is they only do the ABI. So for areas that are not close to those areas, like you say, nationwide, they actually can go to this screening to rule it out or see how high, the indicator is to say they need further testing. And they can come to Vascular Institute. So to me, that is very, very, is going to be very, very popular in our area, advantageous, because there are rural areas that we can't get to, our ultrasound techs can't get to quickly. So we'll have those mobile systems intact so that when those folks go out and do these testings, they can report back to us. So a lifeline screening will report to us of the findings. And then our doctors could then take shape and say, these are the things that are necessary, ultrasound or then offering procedure. So I'm really excited about that because there are going to be quite a few events in the Sacramento area, in outlying areas of Sacramento, and also in our Arizona and our Texas area. And so that will make us more broad in the areas where we can't get to. So that's preventative measures, because these folks that are going to be going to lifeline screening, they are proactive. They are actually paying for this testing to be conducted.
Okay.
And it's wonderful. So in key with that is, I want you to pull up that picture. It talks about diabetic care.
Yeah.
That one, yeah. So, you see that there?
Is that this one right here?
Okay. No, then the other one. It has black background. Yeah, the real cost. Okay. Yeah. So what Dr. Aitali was talking about is, having a podiatrist is so, so important. Reason being is, look at the costs that are associated with diabetic foot health. And then, of course, we as Vascular Institute definitely want to prevent these things from happening. However, if it's too critical at that time, then we do step in. The doctors then will perform the interventional radiology procedures. However, with that said, is we reduce the costs not only for the patient but for our society. Because look, when the cost of diabetes in the United States is $245 billion. That's nationwide. And then you look on the left at the investment of care, the difference between having a podiatrist or having a doctor in your pocket that is supporting you when you have diabetes, and when you have this neuropathy, and when you have, all these particular conditions related to diabetes that can definitely be managed. And then we are on the back end where when those things fail, then Vascular Institute takes shape. What I had mentioned in the first segment as well is the Vascular Institute is a limb salvage program. We want to save those legs. We want to reduce amputation. And by that said, with the amount of money that it costs to amputate, and then also the fact that a patient is depressed or saddened by the fact that they've actually lost a limb, we want to reduce that. We want to say, hey, come in Vascular Institute. We will get it fixed for you. Just like Dr. Aitali said, they go out on outpatient in a couple hours, 4 hours, and they're walking again. And it's miraculous. I've seen the procedures done. I think it's just absolutely a phenomenal procedure that's benefiting a lot of folks, 50 plus. Dr. Aitali said smokers, diabetics, high blood pressure, high cholesterol, things like that. So we want to outsmart diabetes. We want to outsmart all the conditions related to PAD. Mm. And we want to also outsmart it in regards to venous insufficiency. That's another side note. We talked a little bit about that in the first segment. Yeah. But peripheral artery disease is just something that a lot of people do not know about. And Dr. Aitali says, yes, then when it's too late, it gets critical. And we want folks to come in. We want, go see your podiatrist, contact Dr. Aitali, for deeper questions or consultation. Because it's if you're strategic about it, just like we are in everything we do in life, we try to be strategic in the different things we do with work and life. And if we can do that, then we are kind of being proactive, but more importantly, we're surviving. Those folks will survive later in life and be able to enjoy that life with their families and friends.
Awesome. I love that. It's all goodness, right? I mean, again, just preventative care. I said that was going to be the last question, but now see, here I come coming out of left field. This is what I do. So, doctor, yeah, the crux of the conversation has been around PAD, but what comes in your office on a percentage basis, right? Is it focusing on these types of things that we're talking about right now? But again, is it maybe folks that have tripped and broke their ankle while trying to run a marathon when they probably shouldn't be running? What's the patient load? I guess what are you seeing a lot of? And to piggyback on that, has it changed within this year during the pandemic, right? Since folks really can't go out and do a whole lot of other things, so maybe they're trying to take up mountain biking and running or whatever the case may be. What does that look like for you on a day-to-day basis?
So I'm lucky enough to where I get to see, at least initially prior to the pandemic, the whole gamut: sports medicine, overuse injuries, trauma, wounds, infections, arterial disease. So essentially we're like primary care physicians for the lower extremity. That's what you can think of a foot and ankle specialist as. We treat anything from bunions to ankle fractures to everything in between. Okay. So the way in which the pandemic has changed things for us is, unfortunately, it's made the real victims are the diabetic folks, because being unable to seek out treatment or get treatment in a timely manner, it has led to an increase in my caseload of infections, wounds, and unfortunately amputations. Because as we were saying earlier, preventative care really does prevent catastrophic outcomes. And if you're unable to get that preventative care or even that maintenance type of care, then whatever small issue was there in the beginning, after 3-4 months of lack of proper care, it's certainly going to be worse. And that's the biggest effect we saw with the pandemic. Gotcha. Unfortunately.
Yeah, that's so I wasn't expecting that, and so you kind of threw, and so that's the reality of it, though, right? Again, and I think we all needed to hear that, right? In terms of that's kind of like my pastor would say, make it plain. That's the plain, unfortunate negative of how the world has shifted, and unfortunately your caseload is growing because of those types of situations. Sir, thank you for your time.
That's true.
Thank you for the information. Definitely valuable. Jennifer brought you on. She said you was a superstar, and next thing you know, and he comes in with the hat on and everything, dropping knowledge, and I love that. Jennifer, because folks are going to go to you as opposed to, I think for the most part, going to the doctor, because he's got his processes and frameworks in terms of bringing on caseloads and things like that. Tell folks again, but I will put it in the show notes, how to reach out to the Vascular Institute for more information.
It's quite simple. the first opportunity is to go to myvascular.com. That's www.myvascular.com. They can actually take a quiz online.
Oh, wow.
And they can ask a couple questions, and it leads them to the next question is, would you like to have a consult? So they can put their name and phone number, email, and then we connect with them. They can actually connect online as well. There is a button to push to actually call directly. And that phone number in Sacramento is 916-680-9510. But online, there's actually an 800 toll-free number, and that's there. And like I said, you can click on it. I want to point out one thing, in addition to what Dr. Aitali said about the pandemic. We have telehealth. And what's extraordinary about that is if a person cannot come into our office right offhand, we can offer telehealth. The doctors will examine over the, like what we're doing right now, over camera, or maybe over the phone. But based on the criteria that patient offers, is then we'll say, we're going to get you in. And that's really important to stress, because at least they'll feel like someone's on their side, and they'll be willing to come in. And because we're outpatient, we're not like, an office where, there's tons of folks in there. It's more one-on-one. So it's very, very simple for a patient to come in and be one-on-one with the doctor. So I just wanted to pinpoint on that, because we definitely would recommend, if they can't come in right off the bat, is to schedule a telehealth appointment.
Take advantage of the technology that they have and get that care. That's a
even
perfect
a phone call.
Yeah, that's a perfect segue right there. So, folks, again, do what you need to do. Take care of yourself. You've got resident experts here who have come and shared some knowledge with us. Take heed. If something doesn't feel right, something's not right. Don't be afraid to make that call and have that conversation. Jennifer, thank you very much again for your time. Dr. Aitali.
Thank you.
Me and you need to hang out. You're a pretty good guy. You're cool. Thank you guys again for your time.
Thank you, James.
And I look forward to having more conversations down the road. You guys be well.
Thank you very much.
Thank you. Yep.